Swallow right now and pay strict attention to the physical sensation at back of your throat. There is a coating there. It's not something you can cough up, and it's not something you can simply swallow away. It adheres to the tissues. If you have been dealing with this persistent throat mucus, you have likely attempted to clear your throat hundreds of times over the past few months. You have increased your water intake. You may have tried over-the-counter antihistamines or throat lozenges, and the coating returned next morning with the exact same viscosity. The reason those standard approaches fail comes down to the structural paradox in human anatomy. You are treating the throat as if it's a mucus-producing organ. It's not. The throat is transit corridor. When mucus accumulates there persistently, it always have a localized defensive reactions to an irritant originating from one of two neighboring systems: the sinus cavity above it or the gastrointestinal tract below it. Because the symptoms manifest in the throat, both you and your previous doctor have likely directed the treatment at the throat itself. But to resolve the accumulation, we have to identify which of those two neighboring systems is sending the distress signals, and specifically what mechanical trigger is initiating that signal during the hours you are lying flat asleep. The most common origin point for persistent throat mucus in adults over 55 is not the nose. It's the stomach. But it does not present like traditional acid reflux, which is why it consistently avoids diagnosis. Traditional gastroesophageal reflux disease involves a failure of the lower esophageal sphincter, the muscular wall between the stomach and the esophagus. When that lower valve leaks, liquid acid enters the esophagus. The lining of the esophagus is built with tough squamous cells designed to withstand that acidity. You feel this liquid acid as heartburn or indigestion. There is a second valve at the very top of the esophagus, just below the vocal cords, called the upper esophageal sphincter. This muscle is primarily designed to keep air out of the stomach when you breathe, and to keep the food out of the airway when you swallow. As connective tissues loses elasticity with age, this upper valve begins to relax slightly during the deep sleep stages. When it relaxes, it does not allow the liquid acid to enter the throat. Liquid acid is heavy and relies on gravity and significant pressure to move upward. Instead, the relaxed upper valve allows a microscopic aerosol mist of stomach vapor to escape upward. The tissues of the pharynx and the vocal cords do not have a protective cellular lining of the esophagus. They are highly sensitive to any change in pH. When that microscopic acid mist makes contact with the throat tissues during the night, the body initiates an immediate chemical defense. Goblet cells in the throat lining are signaled to secrete a thick, sticky layer of mucus to coat the tissues and prevent the acid vapor from reaching the underlying capillaries. You don't feel heartburn. You don't feel indigestion. You wake up 8 hours later with a throat full of thick mucus. And because you felt absolutely no stomach discomfort during the night, you logically assume the problem originated in your throat or your sinuses. This specific mechanism is called laryngopharyngeal reflux, and it operates entirely on vapors dynamics rather than liquid dynamics. If the upper airway is clear of that acid mist, the second origin point is sinus cavity. What the mechanism that drives it is frequently misdiagnosed as seasonal allergies, resulting in effective treatment. In health state, the sinuses produce roughly a liter of mucus per day. This mucus is very thin and watery, consisting mostly of water and few proteins. It travels down back of your throat constantly, and you swallow it without ever noticing. When your body detects aerosols, stomach acid in your upper way, even at microscopic, non-burning level, it triggers a weak autonomic nervous system response. The vagus nerve, which runs from brainstem down through the chest and abdomen, interprets the throat irritation as potential upper respiratory tract. In response, the brain sends an afferent signals back down that nerve pathway to the blood vessel inside the sinus's lining, causing them to dilate. The sinus tissues becomes inflamed. It does not become inflamed enough to cause facial pain or severe nasal congestion. It becomes inflamed enough to change the chemical composition of mucus the sinuses produces. The sinus gland shifts from producing thin, clear mucus to produce a thicker, slower-moving mucus rich in protein called mucin. This thicker mucus begins to drain down the back of the throat continuously, a process known as postnasal drip. The throat, already irritated by the stomach vapor, now has to manage a slow, steady trickle of thickened sinuses mucus. This is precisely why antihistamines frequently fail in this demographic. Antihistamines block histamines, which is an immune process triggered by the environmental allergens like pollens or pet dander. The sinus inflammation triggered by the vagus nerve in response to the stomach acid is a neurological reflex, not an allergen reaction. Antihistamine does nothing to stop the nerve signals from brain. Worse, antihistamine has a significant anticholinergic effect, meaning they actively strip moisture from the tissues. The result is thickened sinuses mucus that is now also dehydrated, making the physical sensation of coating in the throat significantly worse. The third variable that dictates mucus behavior is not environment, dietary, or structural. It is entirely pharmacological. There are widely prescribed class of blood pressure medication known as ACE inhibitors, like lisinopril, enalapril, and ramipril. They are highly effective at lowering blood pressure by blocking an enzyme in the kidneys that normally constrict blood vessels. However, blocking this specific enzyme has secondary systemic effect. It prevents the body from breaking down a naturally occurring peptide chain in the blood called bradykinin. Bradykinin is potent vasodilator. It causes blood vessels to expand and become highly permeable. When bradykinin accumulates in bloodstream, because the enzyme that destroys it blocked, it begins to leak out of the capillaries and into the surrounding tissues. When it accumulates in the tissues of the throat, the local capillaries begins to leak small amount of plasma fluid directly into the mucosal lining. This fluid causes the tissues to swell slightly. It also alters the viscosity of the mucus secreted by the throat lining, making it noticeably stickier and more elastic. The clinical details that completely hides the connection is the timeline of the side effects. This throat irritation rarely appears immediately after starting the medication. It typically takes 4 to 12 weeks for the bradykinin levels to build up sufficiently in the local throat tissues to trigger the persistent physical urge to clear your throat. If a patient starts a blood pressure medication in January and the throat clearing begins in March, the neurological association is almost never made by the patient. They assume they have caught a lingering cold or developed a mild allergy. They treat the throat with lozenges. The medication continues, quietly accumulates bradykinin in the tissues. The mucus continues to thicken. There are alternative blood pressure medications, specifically a class called ARB, that lower blood pressure through a different pathways and do not cause bradykinin accumulation, like losartan. But the mechanical connection between the blood pressure drug and the throat symptoms must be identified by the mapping the timeline before the medication can be changed. The fourth mechanism is hydration. But the clinical reality of the cellular hydration is fundamentally different from the generic advice to simply drink more water. Mucus is roughly 95% water. Its physical behavior, whether it flows smoothly or whether it sticks to the tissues, is determined entirely by its water content. To get water from the bloodstream into the mucus, it has to cross the epithelial cells that line your airway. The cellular transfer is managed by the specific protein channels embedded in the cell walls, called aquaporins. Aquaporins act as a microscopic gates, pulling water from bloodstream into the airway tissues to maintain a moist surface. Clinical research demonstrate that the expression of aquaporin channels in respiratory tract decreases as we age. The gates becomes fewer in number and slower to open. Simultaneously, the hypothalamus, the part of the brain that register dehydration and trigger the sensation of thirst, become less sensitive to change in blood concentration. What this means structurally, and older adults can be in state of mild chronic dehydration that directly reduces the blood content of their respiratory mucus, makes it viscous, sticky, and slow-moving without ever feeling the sensation of thirst. If you wait until you feel thirsty to drink a glass of water, you are already significantly behind the physiological curve. The mucus in your throat has already thickened due to the lack of the aquaporins-mediated hydration. Pouring a glass of water at that point does not instantly hydrate the throat tissues. The water must be processed by the digestive system, absorbed in the bloodstream, and then transported to the respiratory cell. It is a delayed systemic process. To maintain mucus fluidity, water intake must be consistent and preemptive, entirely bypassing the unreliable thirst mechanism. Aerosol reflux, the vagus nerve cyanosis reflux, bradykinin accumulation, and aquaporin downregulation do not operate in isolation. In the majority of the persistent treatment-resistant causes, two of them converge overnight, creating a compounding physical effect that makes the mucus feel cemented to the throat. The most common convergence is aerosolized reflux combined with mouth breathing. When you breathe through your nose, the nasal turbinates, bony structure in the nasal cavity, slow down in incoming air, forcing it over a large surface area of the moist tissues. This warms the air to body temperature and saturates it with nearly 100% humidity before it ever reaches the back of your throat. As we age, or due to subtle structural changes in nasal passage, nighttime breathing can shift from nasal to oral. When you breathe through your mouth, you are drawing unfiltered room temperature air directly over the back of your throat for 8 continuous hours. This creates a physical process called evaporative cooling. The moisture on the surface of the throat tissues begins to evaporate into dry, moving air. If the throat tissue is simultaneously dealing with microscopic acids missed from the stomach, it is already producing thick protective mucus to coat the area. The mouth breathing then acts as a continuous fan, blowing over the coating. It rapidly dries the surface layer of the mucus. The mucus loses its water volume, becomes highly tacky, and adheres firmly to the tissues, instead of being smoothly swept away by the normal swelling. You wake up with dry, sticky, heavily coated throat. You assume it is a mucus overproduction problem, when structurally it is moisture evaporation problem compounding a chemical defense problem. Treating it requires addressing both the source of the acid vapors and the route of the nighttime airflow. To disrupt this cycle, the intervention must be precisely timed to match the physiology that creates it. Tonight, stop all caloric intake 3 to 4 hours before you lie down. Gastric emptying takes roughly 2 to 4 hours, depending on the macronutrients content of the meal. If you eat, gastric emptying takes roughly 2 to 4 hours, depending on the macronutrients content of the meal. If you eat and then lie horizontally within an hour, the stomach is still active processing. Physical pressure of the stomach against the lower esophageal sphincter increases the likelihood of the both liquid and aerosolized acid moves upward. 3 hours of upright time allows the stomach to emptying, remove the physical pressure, and reducing the volume of the acid vapor available to drift upward. Elevate the head of your bed. Don't accomplish this by stacking pillows. Stacking pillows flexes your cervical spine. When your neck is bent forward, it physically compresses the esophagus, creating a bottleneck that actually makes it harder for swallowed substance to descend and easier for vapors to become trapped at the top of the esophagus. You need a firm wedge placed under the mattress itself or under the legs at the head of the bed, creating a straight 15-degree incline from your hips to your head. This uses gravity to pull stomach contents toward the intestines rather than allowing vapor to drift upward towards the upper esophageal sphincter. Tomorrow morning, before you consume anything, before coffee, before food, drink 16 ounces of plain warm water. Even with wedge built, evaporative loss occurs in the airway. The warm water begins to rehydrate the mucosal surface, losing the overnight accumulation, so it can be cleared rather than remaining stuck to the tissues, where it will trigger a mechanical urge to clear your throat from the rest of the day. This week reviews your medication list with the strict focus on our timing. Write down the exact month and year you started any blood pressure medication and the exact month and year the throat symptoms begins. Take that written timeline to your pharmacist or prescribing physician. Ask specifically if the medication is an ACE inhibitors and if an ARB would be an appropriate substitution. That controls your blood pressure without getting the bradykinin side effect. Ongoing, you must separate your hydration from your thirst. Set 3 structured prompts on your phone: mid-morning, mid-afternoon, and early evening. When the prompts appear, bring 6 to 8 ounces of water. This maintains a steady baseline of blood volume, ensuring the aquaporin channels in your throat tissues have continuous supply of moisture to pull from, keeping the mucus at a thin, fluid consistency rather than sticky polymer. The specific combination of mechanism, vapor dynamics, neurological reflexes, pharmacological peptides, and cellular hydration amounts for the vast majority of the persistent throat mucus in older adults. It is measurable mechanical issue, not a systemic tissues. However, persistent throat symptoms can often indicate tissues changes that require diagnostic imaging, a direct visualization by a specialist. You need to schedule an appointment with a physician immediately. If you notice mucus that is consistently changed with red or brown, which indicates microbleeding in your upper airway. If you experience progressive difficulty swallowing solid foods. If it feels like food is physically lodging in the esophagus, rather than just mucus being present. That requires an evaluation of the esophageal structure. If you develop a firm, fixed lump on the side of your neck that does not move when you swallow, or if voice undergo a permanent drop in pitch that does not recover by midday, those are structural red flags. They fall entirely outside the scope of the behavior management. If your throat is coated right now, the origin of that mucus is not mystery. It is localized physiological response to one of the 4 mechanical pathways we just covered. Identify which pathway is active in your specific physiology by looking at the timeline of your symptoms and at the specific sensation in your throat. Apply the targeted intervention that matches that pathway.